Good afternoon, everyone. I see that we have several people joining us, so we're going to wait maybe another minute and then we'll get started. Okay, I think we're going to go ahead and get started. We've got a full day today, so we're trying to stay on track and keep everybody on time. Welcome to PWSA USA's first Sleep Summit and our second presentation of the day. We're very excited. We had a great session first with Matt Horsnell, and now we are getting ready for our second session. I'm Paige Rivard. I'm the CEO of PWSA USA and mom to Jake, age 12, living with Prader-Willi syndrome, who actually has his own sleep issues. So as many of you are aware, sleep issues are common in our community. And these issues can range from things like lack of sleep, central and obstructive sleep apnea, daytime sleepiness, cataplexy, narcolepsy, just to name a few. And I apologize if you were on the first one. I sort of went over this as well, but we're excited to have all of our amazing speakers today who are specialists in the area of sleep, sharing their knowledge with us. And there will be time for questions at the end of Dr. Ravana's session. So if you have questions, please type them into the Q&A section. The chat is disabled. We are recording the session, and these will be posted on our YouTube channel and social media by the end of the week, maybe a little bit sooner if we get everything together. I'd also like to say a special thank you to our sponsor, Harmony Biosciences, for helping us make this valuable sleep summit available to our community. Without further ado, I'm going to introduce Dr. Amy Ravana. Dr. Ravana is an associate professor of pediatrics at Texas Children's Hospital, and she will be sharing her presentation today, Introduction to Sleep and Sleep Disorders with Children in PWS. Dr. Ravana is a triple board certified physician in general pediatrics, pediatric pulmonology, and sleep medicine. And as I mentioned, she cares for children at Texas Children's Hospital in Houston, Texas. She has a strong interest in medical education and research. Welcome, Dr. Ravana, and I will turn it over to you.
Thank you so much for having me. I'm going to share my screen. Can everyone see it?
Yes.
Yes.
We can see it. Yep.
So I have two financial disclosures, both of which I will not be talking about either of the work that I'm doing in this presentation. But I have two objectives to share with you today. One is to briefly discuss normal sleep patterns in typically developing children in comparison to children with Prader-Willi syndrome. And then the second is to list common sleep disorders in PWS, along with common diagnostic tools that we use, as well as some treatment modalities that are available in this patient population. This is very, very brief, and because of the fact that this in and of itself, both of these topics can be conferences that are days long. And so I hope to give you at least a highlight of what these things are and what's available in this patient population. So why should we care about kids sleeping? Kids are not just small adults. What we know in the adult literature cannot just be applied to children. This is the mantra of all pediatrics, whether you're pediatric sleep, whether you're a pediatric psychiatrist. It's a totally different world. And that's mainly because children are growing. And so their needs are different when they are first born to when they're adults or are transitioning into adult age. And so when we talk about sleep in general, there are different stages of sleep. We can divide it up into non-rapid eye movement sleep in comparison to rapid eye movement sleep, otherwise known as REM sleep. And so non-rapid eye movement sleep is early stages of sleep. As you're beginning the night, your eyes get a little bit heavy, and you can go into stage 1 and 2 of sleep. And then stage 3 is a little bit deeper. We call this slow wave sleep. And this is where growth hormone is released. It's also the where thyroid hormone can be released. This is also where atypical behaviors can happen as it transitions into other stages of sleep, such as night terrors, sleepwalking, sleep talking, and other parasomnias that we know of. Rapid eye movement sleep is very important in growth. This is the dream state. It's very metabolically active. We know in animal models that there's higher brain oxygen consumption during REM sleep in relationship to when you're awake. So most people think that sleep is a period of time in which nothing really happens, which is really the opposite. Every 90 to 120 minutes, you're going to go through a REM cycle. So you start off with non-REM sleep, go through 1, 2, 3, and then hit REM cycle. The REM cycle is about 18 to 20% of the total sleep time. And so you should have about 4 or 5 sleep cycles that include REM every night. And so I'm emphasizing how important REM sleep is, mainly because our children are going to school, they are learning everything about their environment, they're learning on daily activities of living. And so REM sleep is essential for learning and memory consolidation, which is why a lot of studies are focused on the amount of REM sleep. And so when we talk about good sleep in general, not only do we want to talk about the different stages of sleep, but you also want to talk about 4 other items. One is timing. So are you sleeping during the day, or like some of these night shift workers where they have to work at night? Or are you actually sleeping at night and then during the day you're awake and alert? The amount of sleep per 24-hour period is important as well. So, you know, is your child sleeping 12 hours or are they sleeping 5 hours? And then the proportion of sleep is important too. So are you getting the normal amounts of REM sleep that you should, the 18 to 20% of the total sleep time, or are you getting less than that? And then continuity is important. So, you know, you could say that your child sleeps 9 hours per 24-hour period, but is it every night, or is it just the 5 days out of the week that's a school night, and then on the weekends they're more sleep deprived because they're doing all kinds of activities while instead of sleeping? When we talk about sleep, we also look at a roadmap. This is what it's called, a hypnogram. This is what it looks like. The x-axis is hours of sleep, and then the different stages of sleep is on the y-axis. And so I mentioned on the last slide, every 90 to 120 minutes, you go through a REM cycle. And so as you can see, these dark bold lines is your REM cycle. And as the night progresses on, the REM periods and these dark bold lines get longer and more frequent. And so this is what you typically see, the shortest at the beginning of the night, but then early morning to late morning, you'll see more periods of REM sleep. Sometimes I tell families, you know, if your child wakes up and says they remember their dream from last night, most likely they were in a REM cycle when the alarm went off or when you woke them up and they were able to recall. Because during REM sleep, you're able to remember things, and that's how you consolidate what you are trying to make memories during the day. And so in PWS, things are a little bit different. So your overall amount of REM sleep is slightly less. Usually it's about 14 to maybe 20%, if that, but they also have a lot more awakenings. And so it's more interrupted. And so I have this to show you. And so this is one typical example of what their REM cycles look like. They're very short. And then they can get longer as the night progresses, but it doesn't get long enough as you would see in the previous slide. And you can see there's more frequent REM cycles. So there's 1, 2, 3, 4, 5, 6, 7 cycles in this sleep period. PWS patients also have a lot more awakenings, and they're not always secondary to something. So they can be spontaneous. And so that also contributes to less total sleep time. So their sleep is fragmented. They might be more sleepy during the day. They might also have more REM cycles, but overall the amount of REM is less. When we talk about the sleep center, we talk about the suprachiasmatic nucleus of the hypothalamus. And so this is where most of the PWS issues come from, the hypothalamus. And so this little teeny tiny area regulates sleep. This is where your clock is regulated. So if you're a morning lark versus a night owl, this is where it comes from. And so as a result of having hypothalamic dysfunction or problems of the hypothalamus, you can have various clinical findings and symptoms at different ages. And this is just particularly in PWS. In infants and toddlers, when you have this hypothalamic dysfunction, they can present with daytime sleepiness, although it's more common in older kids. But some parents do find that the daytime sleepiness impairs their daily function, and so it prevents them from having good learning. They may have behavioral problems and as well as poor motor development. In addition to just behavioral and cognitive problems, they also have appetite dysregulation and feeding difficulties. Again, all related to the area of the hypothalamus. And as a result, they can have failure to thrive. They also could have craniofacial abnormalities and just the generalized low tone, also known as hypotonia. And so this puts them at risk for sleep disordered breathing, which I'm going to talk about a little bit more in depth later on. But sleep disordered breathing in the form of obstructive sleep apnea, central sleep apnea can present in various ways. But the more common symptoms are snoring, pauses in breathing, choking for air or gasping for air during sleep. All common things that can occur and present in children and infants and toddlers with PWS. So as PWS children grow and become adolescents, they still continue to have hypothalamic dysfunction, but their excessive daytime sleepiness becomes more pronounced. They continue to have cognitive dysfunction, behavioral problems, learning problems. They still have poor motor development. And this is where sleeping problems become an issue. So as they get older and go towards adolescence, puberty becomes a problem in general, in typically developing children. But they also affect kids with PWS as well. And this is mainly because there's different hormones that are regulating your sleep, and it produces a shift. And this shift is delayed by 2 hours. And so their sleep time may not be where you would expect it to be when they were before puberty. And, after puberty shift, their sleep patterns may not revert back. And so they continue to have problems with falling asleep, staying asleep, daytime sleepiness. As a result, they still have appetite dysregulation. Kids with PWS also have hyperphagia, food-seeking behaviors, which contributes to obesity. And these alone can also contribute to obstructive sleep apnea or central sleep apnea, and can cause more pronounced snoring, pauses in breathing, choking during sleep, as well as apneic episodes. So we know that typically developing children have difficulty with sleep, and that's about 25%. This was done through an epidemiologic study. There are plenty of studies out there that also show that PWS children also have difficulties with sleep. And the consequences that they have as a result of having sleep problems is a lot. Excessive daytime sleepiness, it impacts their cognitive behavior, regulation of affect and mood. They have learning problems, which also present in school. So teachers are starting to see this as well. There's also health outcome data that's out there that show that long-term problems with sleep in PWS can result in cardiovascular and neurologic impairment as well. We also know the impact that it does on the quality of life. And there's also an extra burden on caregiver and family dysfunction as a result of not sleeping well overall. So now I'm going to shift towards what are the most common sleep problems in Prader-Willi syndrome? And I'm going to focus on 3 categories, if you will: sleep disordered breathing, chronic insomnia, so insomnia or difficulty with sleep more than 3 months in duration, and excessive daytime sleepiness in the form of narcolepsy like features or hypersomnia. And so when we talk about sleep disordered breathing, it's not just obstructive sleep apnea or central sleep apnea, but it's a combination. Children with PWS can have a combination of obstructive sleep apnea as well as hypoventilation. Hypoventilation means that you retain carbon dioxide instead of exhaling it when you're inhaling oxygen. They tend to retain it. And so as a result of that, their breathing becomes more shallow, and they can also present with central sleep apnea, which is where there's no airflow and no effort because the brain is not sending a signal to take a breath. And as a result of these things, you can also have a component of where oxygen levels drop. And so we call these desaturations or episodes of hypoxemia. So you can have one individualized component, or you can have a mix of various conditions, but all of it is characterized under the title of sleep disordered breathing. It can present in many ways, which makes it very difficult for us to diagnose it. Some kids snore, some kids don't. We know that the loudness or the audibility of hearing your child snore does not predict how severe the breathing is during sleep. So the kid that snores really, really loud, I've had surprises where parents are like, I'm sure that my child has severe obstructive sleep apnea because I can hear him down the hallway. And it turns out it's not that severe. And then I have the other way where there's a child that's sleeping very quietly, but has restless sleep and has severe obstructive sleep apnea. So the snoring can be present, but it may not predict how severe the breathing issues are during sleep. Parents can also witness pauses in breathing, otherwise also known as apneas. There could be choking or gasping for air during sleep. Some kids, because of the fact that they know they're not able to breathe properly, might toss and turn a lot in their sleep and thus not be able to go through all the different stages of sleep like they should. And so they wake up not well refreshed in the morning. Some kids, they need more than 1 or 2 pillows to sleep on because that helps them prop their airway open and allow them to breathe a little bit better. And then excessive daytime sleepiness can also be a presenting sign that they're not breathing well during sleep. So there's some tools that we use to help us diagnose sleep disordered breathing, whether it's obstructive sleep apnea versus central sleep apnea, or other forms of sleep disordered breathing. And this is mainly history and physical examination. What is the background of the child? What is their medical history? What things go through the family history that can help us indicate that this child is at more risk for sleep disordered breathing? Physical exam can be very helpful. Are there facial features in addition to height, weight, as well as vital signs? The gold standard to diagnose sleep disordered breathing is the sleep study. We do sleep studies in our lab from newborn all the way up to adult age. And this is a typical setup where there's leads on the scalp, there's leads or stickers right by the eyes so that we can help detect eye movements, which help us determine whether you're in REM sleep or not. There's some sensors right under the nose as well as inside the nose that help us determine airflow. There's a microphone that can help us determine whether or not they're snoring or not, or if they're talking in their sleep. There's a couple belts around the chest and belly to help us identify whether or not the body is doing what it's supposed to be doing in reflection to whether there's breathing movements or not. There's an oxygen probe to measure oxygen saturations, leg movements. There's always a video because sometimes we have some kids who have abnormal movements and we're worried about seizure activity versus just restless sleep. And then obviously there is a technologist, and in some labs like ourselves, we have a respiratory therapist who's also observing the child as well. So what are some treatment options now that your child has been diagnosed with obstructive sleep apnea or central sleep apnea? What are some things out there that could be helpful? In infants, supplemental oxygen in Prader-Willi syndrome has been shown to be helpful in children with central sleep apnea as well as in obstructive sleep apnea. As they get older, though, the oxygen isn't very helpful, and they need something to help stent the airway open and allow the child to breathe, whether it's central sleep apnea or obstructive sleep apnea or a combination of both. And so the common forms of positive airway pressure is CPAP or continuous positive airway pressure, also BiPAP, bilevel positive airway pressure. And both of these modalities are very common in the PWS population, although there are many challenges that come with the use of CPAP and BiPAP. There is medical management for mild obstructive sleep apnea. That it can include like a nasal steroid, which is a spray, with a combination of an antihistamine or some nasal saline washes if there's sinus disease or other anatomic issues. We do refer most of our kids for surgical intervention or at least an evaluation. Sometimes big tonsils and adenoids can get in the way, especially if a child is going through a growth spurt or if they have had exposure to growth hormone. You can have an increase in tissue, and that can also make your breathing a little bit worse during sleep. Some kids will have some sinus or nasal abnormalities where their nasal septum is deviated to one side or the other, and thus makes it very difficult for them to breathe. And so just alleviating some of these issues can help relieve some of the sleep issues that they're having during the night as well as during the day. Next, I want to talk about insomnia. Chronic insomnia is having problems sleeping for more than 3 months in duration. And this can present in various ways as well. PWS kids can have early morning awakenings, meaning they can fall asleep easily, but then they wake up at 2 or 3 in the morning and they're ready to get their day started. They might have fragmented sleep or restless sleep. I mentioned that, the sleep architecture in PWS they can have spontaneous arousals or awakenings for no apparent reason. Their brain is just offsetting their sleep pattern. And so they wake up, and then some kids can fall back asleep, but some kids can't. And thus they're just awake for the rest of the time frame. Or they wake up not feeling so well rested in the morning, and it appears as though they weren't sleeping all night long, even though they were in their bed and they appeared to be sleeping. They might have frequent naps at unusual times. And so we can talk about that also with excessive daytime sleepiness in the form of narcolepsy or hypersomnia. But chronic insomnia, as a result of not sleeping at night, some kids have to compensate during the day. And so they catnap throughout the day to kind of make up for that lost time that they weren't sleeping. They might have difficulty falling asleep where it takes a few hours, or they need a sleep aid to help with falling asleep, or just staying asleep as well. So some kids, they might have a combination of sleep disordered breathing and insomnia. The snoring wakes them up, or not being able to breathe wakes them up, and thus they're not able to go back to sleep. Not having enough time. So I mentioned that the hypothalamus regulates how much sleep we get. And so in some kids with PWS, they're clocked at 6 hours. No matter what you do or what time you put them to bed and what time they wake up in the morning, they will only be able to sleep a certain amount of time. And nothing can fix that, because that's the way that they're clocked, they're genetically speaking. And then again, excessive daytime sleepiness as a result of not sleeping at night. There's some tools that we have that can help us diagnose insomnia as well. Again, history and physical exam is very important. The history kind of gives us an idea. Was there an inciting event that caused the insomnia to happen? Or is there things in the bedtime routine that is actually wake promoting versus sleep promoting? Physical exam can be very helpful in trying to identify if there's other sleep disorders or other physical findings that can prevent good sleep. A sleep diary, there are various forms. This is from the American Academy of Sleep Medicine. But basically, it kind of records over a 2-week period. We have the parent or the caregiver fill this out and gives us an idea of how many times a child wakes up, what times do they go to bed? Is it consistent? Is it not consistent? Does it happen, consistently over a 2-week period, or is it just a couple of days out of the week? And then we try to compare a sleep diary to something called actigraphy. And so I put a picture of one type of actigraph. Actigraphy is a medically grade Fitbit, if you will. It basically monitors heart rate and movement. And it can kind of give you an idea of how much sleep, which is these green bars right here, how much sleep the patient's actually sleeping at night. And we compare it to the sleep diary. And the reason why we compare it is because if you sit really still and lay really still in your bed, the Fitbit doesn't know any different if you're awake or asleep. So this is just a quick measurement that we could use in the home for a long period of time, as opposed to doing a sleep study that it is quite invasive, has a lot of wires, and again, spending an evening in the sleep lab versus doing this in the comfort of your home. There are some things that we can do to help improve chronic insomnia. The first thing we try to do is maximize sleep hygiene. So try to get the child to wake up and go to bed at the same time. And it doesn't have to be a very complex bedtime routine, but we like families to incorporate that every day, including the weekends. And that can be as simple as a bedtime story, saying your prayers, changing into your pajamas, brushing your teeth, and going to bed. Something very simple. It does not have to be very long. We like to encourage families to use different techniques while sleeping. So some folks with PWS, they don't like strict silence. And so having a white noise maker kind of helps with mitigating some of the environmental noise or things that might trigger them from not falling asleep. Some folks like to listen to music, so we try to encourage that. But we want a routine. We want something that's done day in and day out so that they kind of get used to it. And then eventually what happens is the routine will trigger the brain to release melatonin and start that process of falling asleep. Behavioral modification, particularly in conjunction with the sleep psychologist. So not every sleep center has the luxury of having a sleep psychologist, but a sleep psychologist can be very, very helpful in trying to incorporate a bedtime routine and incorporating it into the family routine. So, you know, if everyone's working and staying late at work, and having those kinds of routines can be problematic, particularly when you're trying to put other life events into the schedule. And so we know that behavioral modification is much more efficacious in trying to improve sleep hygiene as opposed to using medications and changing your behavior. Although I do have to say, a lot of times, by the time I see patients, particularly in this patient population, families have already tried things. And so they're at their ends with, so trying to just modify behavior isn't really going to be the quickest, fastest way to get to where they want to be. And so sometimes we have to relate to using or sleep promoting agents. And so melatonin is the only FDA approved medication for chronic insomnia in children. Sometimes it works and sometimes it doesn't. There's a lot of data coming out there now about side effects to melatonin, particularly high dose melatonin. And so I always use caution with any medication, but particularly with the new data that's coming out, melatonin can be helpful in helping with only falling asleep. So sometimes I see families, they give high dose melatonin to help them stay asleep, but their child is only going to benefit from falling asleep with this medication. I do want to just mention there are other non-FDA approved medications that we use as off-label to help with falling asleep. And mainly these medications, we use the side effect of sedation or sleepiness as our method of trying to get them to safely fall asleep. And the reason why we use these medications off-label is because we're worried about patient safety. And so if everyone in the home is sleeping, but your child with PWS is not, and they're having food-seeking behaviors and they're at risk for self-harm, that may not be the best thing for the child. So we do sometimes have to revert to medications in that sense. Now I want to shift towards excessive daytime sleepiness, more focus on narcolepsy type features as well as hypersomnia. And I put this together because I think excessive daytime sleepiness has so many contributing factors. And we'll start here at the top. So patients with low tone, they pose a big risk to having problems with daytime sleepiness. And that's mostly because they're having issues with keeping their airway open and not being able to breathe as well as they should, and thus causing fragmented sleep, thus contributing to daytime sleepiness. Mood disorders can affect sleepiness as well. If you're not sleeping well at night, your mood or your behavior during the day will be altered. And if you're not really doing well mood-wise during the day, then you're probably not going to sleep well at night. And so the cycle continues until you break it at some point. Not getting enough sleep can contribute to daytime sleepiness. Remember, I said the hypothalamus is already genetically predetermined how many hours of sleep you need to adequately function during the day. And so for some, it's not enough because they have to get to school or they have to get the bus. And so they don't have enough time to actually get the amount of sleep that they need, or they're just clocked at 6 hours. And no matter how much time you have them sleep, they're still not able to sleep the amount that you want them to. Endocrine abnormalities can contribute to daytime sleepiness as well as sleep disordered breathing. My apologies for the cutoff slide. There are narcolepsy-like features such as cataplexy, which we'll talk about in the next few slides, as well as hallucinations and sleep paralysis that can cause excessive daytime sleepiness. And then again, medications can also contribute to that. And then lastly, obesity in and of itself, I think we know that it can contribute to excessive daytime sleepiness, but there's lots of data coming out now as far as the hormonal effect of obesity and the contributing factors that how it affects excessive daytime sleepiness is still controversial, and there's still a lot to discover about the relationship between the two. So I would like to focus a little bit more on the excessive daytime sleepiness in the form of narcolepsy. Narcolepsy is characterized by excessive daytime sleepiness, cataplexy or loss of tone, sleep paralysis, hallucinations while you're falling asleep or as you're waking up from sleep, as well as fragmented sleep. There are two types. Type 1 is with cataplexy, and if you measure this protein in the cerebral spinal fluid, there's a certain amount that is present in those with cataplexy. Type 2, you have without cataplexy, and I'm sorry, this is a typo, it should be less than 110. And so the amount of hypercretin that you have can determine whether or not you have the diagnosis of narcolepsy. That's the gold standard. However, we don't always do this in children because of the fact, one, it requires sedation, but two, it's a very expensive test and not every lab will perform it. So it's very difficult to get done in a timely manner in order to get a diagnosis. So the gold standard at this time to diagnose narcolepsy is by an overnight sleep study followed by a mean sleep latency test. And a mean sleep latency test is basically a series of 5 naps in which we measure the tendency of how quickly a child will fall asleep. Less than 8 minutes in duration is diagnostic of narcolepsy. I mentioned cataplexy a few times already. This is where you have sudden episodes of muscle weakness that's brought on by strong emotion, mostly laughter, but it can be by extreme anger as well, or extreme joy. It's very difficult in children because usually those findings can be very subtle, particularly in Prader-Willi syndrome. It can present as seizures. I've had some kids where their eyelid will start twitching and they've been diagnosed with tics, facial drooping, as if they were having a stroke of some sort, slurring of the speech, unusual sensation of face, arms, and legs. And this can be very difficult for patients to even relay that, hey, I'm having this sensation every time this happens to me. They may also have lip smacking or twitching. Again, very subtle findings. So unless you are aware of these findings or aware of what cataplexy is, these can be missed until later as you're going through the workup. In particular, I just wanted to focus on sometimes cataplexy can be masked, particularly if there's behavioral outbursts or meltdowns. It could be a form of cataplexy. If they're leaning to one side and laughing, again, eyelid twitching, drooling at inappropriate times, falling episodes is very common and can present as the child being clumsy or having 2 left feet when in fact they're just having a cataplectic moment. Some kids will have staring spells and it'll appear as if they were having seizures, but when they have that workup for seizures, it turns out to be negative. Cataplexy are events where patients are conscious. They could hear, they could feel, they can sense, but they just cannot move during that time frame, or that particular body part is being affected until the event is over. So I just want to take a few moments. I know this slide is very busy, But just a few seconds to kind of compare what we see in Prader-Willi syndrome in comparison to true narcolepsy. There are some subtle differences here, which makes it very difficult for us to pin out whether or not this is truly PWS related or whether it's truly narcolepsy related. But the average time that we know that's been documented in the literature, as far as the average time to fall asleep, is 7.2 minutes. A lot of kids, though, will fall asleep much, much faster than 7.2 minutes. Narcolepsy in general, less than 8 minutes would be the diagnosis. Both populations will have cataplexy, but there may not be a genetic component in PWS as far as in relationship to having narcolepsy. Most patients who have narcolepsy with cataplexy will have some form of genetic component that will identify them as having narcolepsy. Sleep paralysis is not very common and in PWS, and I think it's because of the fact that kids aren't really able to share what they're feeling, and so I personally feel that we might be missing this just because they're not able to relay what they're experiencing. And then lastly, I just want to jump down to the bottom of the slide. Response to conventional therapies that treat daytime sleepiness. So there's a few things that we can use to keep children with narcolepsy-like features to keep them awake. However, it's very uncommon for PWS patients to respond to those therapies. So we try them to see if there's some relief, but they're not as effective as they would be in someone who has the typical features of narcolepsy. So we know that the narcolepsy-like features in PWS is not the same as someone who has narcolepsy. There are some subtle differences. There are limited FDA-approved modalities or treatment therapies that are available for PWS and with narcolepsy features. And unfortunately, as of right now in the US, there's nothing that's really 100% effective in this patient population. We do recommend short scheduled naps throughout the day, and this really allows each patient to have their REM cycle during the day so that they're able to function. A lot of patients who nap throughout the day and have these cat naps feel refreshed after that quick nap. And then I mentioned some wake promoting agents, mainly in the form of sodium oxybate. There is pitolisant that's out there. Again, all of these are the sodium oxybate has been approved in children with narcolepsy type features, but again, in PWS specifically, it may or may not be as effective as those who do not have PWS. So I know this is a whirlwind tour of sleep disorders and in PWS, but they're very common in this patient population. And as a result of the multiple abnormalities related to PWS, sleep problems can present in various ways, and thus it requires a multidisciplinary approach. Sleep disorder breathing and insomnia are common, but we also have to remember that excessive daytime sleepiness may be under-recognized, as a lot of these kids will compensate by different things like having behavioral meltdowns or issues, or tripping, which is a form of cataplexy. So we have to be a little bit more vigilant about these things. We need more research, more data gathering regarding the natural history of sleep in PWS, because this will help us guide treatment options as well as standardize protocols and screening methods for children with PWS. I want to thank you so much for your time, for giving me time to listen to me. I'll open it up to questions. I purposely left a good chunk of time so that I could help answer as many as I can. Thank you so much.
Thank you, Dr. Ravana. As you said, this could be on, we could go on for hours, and I know that we have several questions, so thank you for leaving time. I will start with the question, awareness is great, but what do we do if we see these symptoms, like symptoms of cataplexy? Any treatments for improving the staring spells or sudden loss of tone from eating, etc.?
So first is to get the diagnosis. So my recommendation is to see a sleep specialist so that you can get the proper workup and make sure it's the right workup. Make sure those episodes are not seizures. And then I mentioned having the sleep study to rule out other sleep disorders that can cause sleep deprivation, followed by the mean sleep latency test. That'll give you the formal diagnosis of narcolepsy. As far as treatment modalities for cataplexy, there isn't really one thing that has been approved yet. And I say yet because there are studies that are actively going right now as we speak. So just stay tuned for that. But as of right now, there isn't really one thing or many things. There's really nothing out there that can stop these episodes except being aware that these episodes will get better with time if they sleep more and you kind of are more vigilant on what to do during these episodes.
Dr. I know that your specialty is in pediatrics, but there is a question asking whether or not the information that you're providing also applies to the adult population with Prader-Willi syndrome.
For the most part, yes. So my adult PWS, even though I am at a pediatric hospital, I do see adults with PWS as well. And for the most part, a lot of their issues do continue on into adulthood, especially their sleep issues, sleep disordered breathing, their issues with CPAP and BiPAP and trying to tolerate their masks is always a constant battle. As far as treatment modalities for excessive daytime sleepiness in the form of narcolepsy-like features, it's a little bit easier to get them approved, at least trials to see if it's effective or temporary effectiveness by insurance companies. So that's one big plus of treating the adult side of things in PWS. But like I said before, a lot of the modalities that we use are not really helpful.
Thank you.
There's a question on hormone replacement. Do you recommend hormone replacement in adolescents to normalize sex steroids to correct some of the hormone dysregulation? And how does this impact sleep?
Yeah, so hormones affect a lot of things. It affects your mood. It affects, so I'm assuming hormone replacement, you're referring to at the time of puberty onwards. And so I recommend hormone replacement in conjunction with meeting regularly with your primary care physician, gynecologist, whoever it is. And that is mainly because those hormones can also affect sleep. They can cause you to become more moodier and prevent you from falling asleep or staying asleep. It can also contribute to excessive daytime sleepiness. So if you already have narcolepsy type features, having a hormonal imbalance or just having a menstrual cycle in between can actually make things worse. I have some patients where their daytime sleepiness is much worse when they're having their cycle, but gets much, much better once they're off their cycle. And so I do trials, we try some birth control or oral contraceptives to see if that makes a difference. Some do, some don't. But I think it's worth having that conversation.
Great, thanks.
Are there any watches that help track sleep thoroughly enough for a physician's data collection that would show any markers for specific intervention?
So in some cases, especially when access to care is very limited and we can use telemedicine, I think it can be helpful. So, some of these watches that are out there, like I said, you can fool them by laying really, really still and mimicking sleep. However, if there's a specific pattern that your child is showing, like they're sleeping 6 hours during the day, but only 2 hours at night, that can be helpful information. It means that their sleep cycle is reversed and they kind of need something to help them reverse that. So in some situations, it can be helpful. So it's better than nothing, I will say that. So particularly when access to care, you have to travel 5 hours, it'd be good to have that information during a sleep evaluation to kind of see if we need to have something more in the form of more data, or maybe we can bypass that step and move forward to something else if in conjunction to what you brought. Absolutely.
The next question, a lot of us probably deal with this, laptops or tablets that our kids use, before bed. How does that impact sleep, and should it be avoided? And if so, how far, advance of bedtime should we stop using those?
That's a very difficult and hard question to practice. So a lot of the electronic devices, we rely on them, right? So some of them have free apps that have make white noise and play lullabies for our little ones and whatnot. But a lot of those electronic devices, they release blue light. And blue light, unfortunately, stimulates the brain. So some people will tell me I can watch TV for 2-3 hours, not feel sleepy until after 3 hours, or I can't fall asleep until I watch TV. And it's not really that they need the TV. It's just the fact that their brain is just going. Their brain has not been able to turn off. And as a result, their eye muscles are tired. So you feel like your eyelids are drooping and you want to close them because you feel tired, when in fact it's not really your brain that's turning off. It's your eye muscles that are trying to close so that you can actually try and go to sleep. The problem with blue light is some people are very sensitive to it and they can stay up for hours, and some people can fall asleep immediately, but they wake up later. And so we recommend at least 1 hour. If you can do 2 hours of no electronics before bedtime, that'd be great. So this is where, after your bath, after your bedtime routine is started, we try to tell families, try to stay away from electronics as much as you can, to kind of help with that bedtime routine, as well as reducing the amount of light exposure.
Thank you. I think you're right. It's very
hard. It's super hard. I know. I'm a critic when it comes to that. Because everything you do. Oh, sorry. Go ahead.
The next question, for a child who's on modafinil for excessive daytime sleepiness, but just missed the narcolepsy diagnosis, do you find that it's still common for them to fall asleep easily during motion, such as a car ride or a boat ride?
Yeah, I mean, so modafinil, first it depends on the dose of how high of a dose you're on, but the fact that they're sleeping tells me that the medication is not enough, and that goes hand in hand with the conventional therapies that we have for narcolepsy cannot just be applied to PWS. It's just not. It's a different mechanism. I mentioned narcolepsy-like features, and that's it mimics narcolepsy, but the etiology is different. The genetics of PWS in comparison to those of narcolepsy is different. So using these modalities are probably not going to be very helpful. In fact, it probably flags the idea that maybe we should look for other sleep disorders that are contributing to the sleepiness. So making sure that their sleep apnea is not contributing to it, making sure central sleep apnea is not contributing to it, alongside with medications and whatnot.
Great. So this next question that I want to ask, that somebody has asked here, is there a downside to having my teen? And actually, I would just say any of our children, because some of our kids, even in grade school or middle school, drink black coffee during the day to try to help keep them awake. So, do you see a downside to that at all?
There's a downside to everything, but I do say so for some children. Caffeine can be wake promoting. That is what some of these things that we use, like Ritalin, ADHD medications, to keep kids awake in PWS. That's what it is. It's a form of caffeine. It's in that sense. However, caffeine, it's all about timing. So if you're taking it in the afternoon, the half-life of someone who is caffeine naive, it might affect them all afternoon and into the early evening, and thus contribute to not sleeping on time. A lot of times, most of these caffeinated beverages have a lot of sugar, and so that contributes to weight gain. So you have to worry about that. Some kids have behavioral changes too when they're on caffeine. So those are the things that I would think about and have a strong conversation. But I do have some kids, especially with PWS, where they aren't able to handle a medication for whatever reason, to keep them awake. And so we will try, a short trial of a small amount of caffeine, whether it's a Starbucks drink or whatever, to kind of help them get through whatever activity that they want to get through. Mainly it's for standardized testing or some type of testing for school, or a school event that they would try this.
Great, thank you.
The next question here is, and Dr. Singh might be addressing this later in his presentation, but the question is whether or not there's long-term risks of being on trazodone to treat insomnia at night. This child is 4 and has been on it for a few months now.
So long-term risks of any hypnotic agent, so whether it's trazodone, whether it's some other sleep aid, they eventually all stop working at some point. So then you're looking for other modalities to kind of continue on. That's the battle that as a sleep doc we have. But trazodone in and of itself can cause liver issues, so you have to screen for those things. So my advice would be to talk to your physician to make sure that they're monitoring liver function, particularly depending on the dose and the age of the child.
Thank you.
Wow, we're getting lots of questions.
Yes.
So, let's see. Next question. What if our sleep specialist has limited knowledge and understanding of PWS? They're comfortable treating sleep apnea, but beyond that, really can't address excessive daytime sleepiness. What recommendations might you have for that?
Reach out to someone who does. There's a lot of social platforms out there. There's also, well, this is part of why we're here today, is so that we can network. My concern with that is it's not just sleep disordered breathing. There are other things that contribute to why children with PWS have such a hard time with sleep. It's not just having trouble breathing, but staying awake, performing daily activities of living, those kinds of things. So that's a tough thing, especially if you have a certain amount of time during the day to take care of children or any patient, and then on top of that, have limited knowledge and trying to get more. You're more than welcome to send questions to me, and I can help refer and discuss as well, which is very common here at Texas Children.
I think in conjunction with that, another question here is just, can you provide us with exactly what type of workup, we should request when we're seeing a sleep specialist or any physician, I guess, about sleep
So
issues?
the main thing is why are you seeking a sleep specialist? So is it because you're worried that your child is having problems with falling asleep, staying asleep, or are they too sleepy? And so I'm assuming we're referring to if daytime sleepiness. But start with the sleep study, start with making sure that there's a physical exam that's done, and identifying, that'll help us identify what tests need to be done. For insomnia, it's, like I said, it's a sleep diary and a watch. For excessive daytime sleepiness, it's the sleep study and the nap study, or the mean sleep latency test. There could be other labs that we would get, but that would be the place to start.
Great.
Yeah. So what if you notice a cataplexy episode with your child? How do you respond? Do you give them a short break? Do you go about the day? Just what does that look like after it happens? How should a caregiver respond in the moment?
Reassurance, number one, right? Make sure they're safe as well. So I've had some kids have cataplectic events when they're trying to get off the bus and they trip and fall, and bam, they're having an event. So safety is number one. Reassuring them that, this is what happens. Talking to them. I think a lot of these kids know it's happening to them, but being open about these events and not hiding them is very important. Transparency. And as far as how to make these events go away, knowing your triggers. So if you know that having friends over is going to trigger a cataplectic event, then just being aware of that environment is important, and making sure, again, if they do have a cataplectic event, people around them are aware and they're not calling 911 because, it's never been, I've seen that happen. So, it happens. So I think just awareness in general. Unfortunately, there's no medication that you can give to prevent it. But getting adequate sleep, taking short naps, I think also helps. There are some medications like antidepressants that can be helpful. Again, in my experience, it hasn't been successful in PWS, but I do trial them just in case.
Mm-hmm. Thank you.
Sure.
Here's a specific question about my child had a sleep study recently. Her non-REM AHI was 4 and REM AHI was 13. Would you recommend intervention at this point, or just continue to watch?
So when I see numbers like that, one, it depends on the age of the child. If they're closer towards adult age groups, then I would say you should consider it, especially if there's other comorbid conditions like blood pressure issues, diabetes, those kinds of things. That has been proven in the adult literature. As far as REM-related sleep disordered breathing in children, so under the age of 12, 13 years, it's very difficult. And so in my practice, what I do is I balance whether or not they have other symptoms. So if they are falling asleep during the day, they're having difficulty sleeping at night, they're snoring, or they're waking up choking for air, then I do trial and see if CPAP, BiPAP, or any other surgical intervention could be helpful at that point. But if they're asymptomatic and they're doing fine and there's no other problems as far as blood pressure issues, no behavioral issues, those kinds of things, then sometimes it's a wait and see kind of thing. And you just let them, wait 6 months and reassess.
Yeah. Do you have an opinion on levocarnitine supplementation to help with food-induced cataplexy or daytime sleepiness?
There's so little data out there. So I am one to be cautious. I think you have to be very careful with supplements. I'm also not against doing them. I just feel that you have to be cautious and be aware of where you're getting your supplements from. As far as the literature and evidence-based support, I don't have very much to go off on. But when I see families that come to me and they say they want to try it, do one thing at a time is what I recommend, so that if they do react or they have a bad reaction or they have some behavioral outbursts, you can relate that back to whatever you were trialing, and just close monitoring, so transparency. So if there are some supplements out there that can cause heart problems or arrhythmias or kidney problems, especially if you're not hydrated enough, which is the L-carnitine, then I would say talk to your pediatrician or talk to someone that's going to be able to monitor hydration status and kidney function, just to make sure that we're not doing harm versus good.
Mm-hmm. Yeah.
Dr. Ravana, I know you said people can email you, but I'm assuming you're also willing to consult with physicians who might have limited knowledge. Yes. Okay. And you can always contact PWSA and let us know if you need us to help set up that, consultation, or obviously Dr. Ravana has offered to email her. But another question was, our son is 41 and we are having a hard time. I think it's seeing a specialist for him. We live in Colorado Springs. Any suggestions? So I know that's always hard to get a specialist anyway for PWS in general, but are you aware of any specialists in the Midwest area that they might be able to reach out to?
I don't off the top of my head, but that doesn't mean I can't ask around. So I will get back to you and I'll reach out to one of you two and share that info once I find out.
Perfect.
Awesome. Yeah.
Thank you.
Colorado Springs, right? Is that what you said?
Right.
Yeah. I'll find out.
Thank you.
So we're running just about out of time. So I thought we'd ask one more question.
Sure.
How often should somebody with Prader-Willi syndrome who has any of these sleep diagnoses, whether it's apnea or an excessive daytime sleepiness or narcolepsy, how often should they be having sleep studies done?
So the standard is usually when they're growing on a yearly basis, as far as assessing the severity of sleep disorder breathing, because they're growing. But once they hit adult age, so whether 16, 17 years of age, then it can spread out to as needed. And that's dictated by insurance plans. And but clinically speaking, every year for a child, because they're growing, things change, medications change. And so for my PWS patients, I try to do it once a year. If they're on CPAP or BiPAP, then definitely once a year, so that we can make sure we can optimize their support while they're sleeping at night.
Great, thank you. So we do have a lot of other questions here. So I know we're out of time for today. If we send you these questions, would you be willing to,
Sure. Yes.
answer them?
Yeah, send them my way. No problem.
Great. Thank you. Yes, we have still, 10 or 11 questions out here, so that'd be fantastic. Dr. Ravana, thank you so much for your time today. We appreciate it, your knowledge, and we will for sure be talking to you again. And thank you, and everybody. I hope everybody continues to join us throughout the day as we have more of our Sleep Summit webinars. So have a great day. And
Thank you so much, Dr. Ravana.
My pleasure.
bye.